Assalamu alaikum class. I hope you all are doing well. We'll start a new topic today which is very important, and that is integrated management of neonatal and childhood illness, or IMNCI. World Health Organization gave a report in 1999 that children who live in the middle to low income countries are 10 times more likely to die before they reach the age of 5 than the children who were living in the industrialized or the developed world. Now, every year, more than 8 million children in these developing countries used to die before they reach their fifth birthday. Now, 7 in 10 of these deaths were due to acute respiratory tract infections, mostly pneumonia, diarrhea, measles, malaria, or malnutrition, which led to anemia and other conditions. And also, in addition to that, to other causes of neonatal deaths as well. And often there was a combination of these conditions as well. Now, as you know, infant mortality rate and the child mortality rate are the sensitive indicators which tell us about the effectiveness of the MCH services in the country. Now, as you know, the health scenario in Pakistan remains complicated and needs a serious consideration even now. As the health Pakistan Economic Survey, which was reported in June 20, suggested that the infant mortality rate in Pakistan was still 62 deaths per thousand live births, and the under 5 stunted children were 40% and the underweight children were 29%. So the health scenario in Pakistan remains complicated and needs a lot of new policies which should be planned properly. Now, many preventive and treatment strategies have already been proven effective for saving the young lives. Now, childhood vaccinations, as you know, in our EPI program, have successfully reduced deaths from measles or diarrhea or pneumonia. So, even modest improvements in breastfeeding practices have also reduced the childhood deaths. Now, during the mid 1990s, the WHO, in collaboration with the UNICEF and many other agencies, now responded to the challenge in the developing countries to develop a strategy which was known as the integrated management of childhood illness. Now, this strategy, it addresses the aspects of nutrition, immunization, and other elements of disease prevention and health promotion. Now, the basic objective of the strategy is to reduce the death and the frequency and the severity of illness under 5 years of age and disability, and to improve their growth and development. Now, the IMNCI strategy is initiated and adopted by many countries, especially the developing countries, to improve the survival and development of children less than 5 years of age. Now, the IMNCI clinical guidelines, as I told you, they target the children less than 5 years age. Now, the age group that bears the highest burden of deaths from common childhood is the age group which is less than 5 years of age. Now, the case management that supports the rational, effective and affordable use of drugs and the diagnostic tools was included in these guidelines. Now, these guidelines were based on a syndromic approach, and this syndromic approach was used to determine the health problems of the child, the severity of the child's condition, and the actions that could be taken to care for the child. For example, if the child needs immediately hospitalization, that child should be referred to the hospital immediately, or if that child can be managed at home, that child should be managed at home. Now, in addition to that, the IMNCI also promotes the adjustment of interventions to improve the capacity and functions of the health system which is available, and also the active improvement of the family members and the community in the healthcare process. Now, the important strategies of the IMNCI program, it includes the three components. Now, number one component is the improvement in the case management skills of the healthcare staff through the provision of locally adapted guidelines on the integrated management of childhood illness, and the activities to promote that use. Number two component is the improvements in the overall health system of the country, which is required for the effective management of childhood illness. And number three component is the improvement in the family and the community healthcare practices. Now next are the principles of the integrated care. Now the IMNCI guidelines are based on the following principles. Number one, that all sick children must be examined for the journal danger signs, which indicate that the child needs to be immediately referred to the hospital for admission. Now we will talk about the general danger signs later in this lecture when we will do the tables of the IMNCI. Now, next principle is that all sick children must be assessed for major symptoms, like children who are in the age group of 2 months up to 5 years of age. They should be assessed for coughing or difficulty in breathing, for diarrhea, fever, ear problems, and for children who are young infants, like they age from 1 week up to 2 months. They should be assessed for bacterial infection, diarrhea, and low birth weight. Now, all they must be routinely assessed for any nutritional and any nutritional problem, and their vaccination status, any feeding problems, and any other potential problems as well. Now, the third principle of this integrated approach is that only a limited number of selected clinical signs are used, which are based on the evidence of their sensitivity and specificity to detect a certain disease. Now, these signs were usually selected considering the conditions and what facilities are available at the first level of the healthcare facilities of that country. Now, the next principle is that the IMNCI guidelines address mostly, but not all, of the reasons a sick child is brought to a clinic. Now, a child returning to the clinic with any chronic problem or any less common problem may require some different type of care. So all children usually do not come under these IMNCI guidelines. Now, next principle is that the IMNCI management procedures use a limited number of essential drugs and encourage the active participation of the mother or the caretaker in the treatment of children. Next principle is that all the essential components of the IMNCI guidelines is based on the counseling of the caretaker and the mother, about the home care, the feeding of the child, the fluid intake of the child, and when to come back for the follow-up. Now, according to the IMNCI guidelines, the disease or the illness of the child is classified according to the signs and symptoms into three types. Now, you'll see in the tables, which I'll show you later in this lecture. Usually, the color, there are three types of colors are used. Number one is the pink color. When the illness of the child falls into the pink color, this means that the child should be referred to the hospital immediately for admission. Now, if the illness of the child falls into the yellow portion, this means a specific medical treatment or advice should be given to the child. Now, if the child illness is classified that it falls into the green zone, or in the upcoming tables, it is usually it's in blue color. It's not in green color due to some fault in the color coding of the of this laptop. So, when the illness of the child falls into the green zone, this shows that the child can be managed at home and should be sent home. Next is the IMNCI case management process. Now, the case management of a sick child which has brought to the health facility includes a number of important elements. Now, the important elements of IMNCI management process are: number one, the outpatient health facility. In outpatient health facility, number one is the assessment of the sick child. Now, the sick child is assessed according to the tables which are provided by the IMNCI guidelines. Next is, according to the assessment of the child is classified and the treatment of the child is identified. Next, in the outpatient health facility, when the child is classified and is identified for treatment, those who need to be referred to the hospital, they should be referred immediately. Those who need a treatment should be prescribed and given a treatment, and the caretaker of the child should be counseled about the treatment depending upon the classification of the sick child. Next, in the outpatient health facility, important element is the follow-up care of the sick child. Next important element of the management process is the referral health facility. In the referral health facility, when the child is referred to the hospital for admission, emergency triage assessment and treatment is important, and after doing that, the diagnosis, treatment and monitoring of the sick child should be done, and the progress should be evaluated. Now, the next important element of IMNCI case management process is the appropriate home management. Now, in appropriate home management, the mothers or the caretakers should be taught how to give oral drugs to the sick child and to treat local infections at home. And the next is the counseling of the mother or the caretaker of the child about the feeding recommendations which are for the sick child, or if there are any feeding problems, how to deal with those feeding problems, how much fluid should be given to the child, and when the child should be brought back to the health facility. And the mother should also be counseled about her own health, how she can take care of herself as well. Now, depending upon the age of the child and the various clinical signs or symptoms, now the IMNCI guidelines recommend the case management procedures based on the two age categories. Number one is the children which age from 2 months of age up to the 5 years of age, and the next category is the young infants of age 1 week up to the 2 months of age. Now we will start with the outpatient management and assessment of the children who fall in the age group of 2 months up to 5 years of age. Now, as I told you before, that there's an assessment procedure, and as you can see in this slide, there's a proper chart. So these charts are provided by the WHO for the assessment in every healthcare facility. Now, the assessment procedure for this age group includes a number of important steps that must be taken by the healthcare provider of the facility. And these important steps are number one, that a proper history should be taken, and with proper communication with the caretaker or the mother who has brought the sick child to the healthcare facility. And number two, for checking for any danger signs. Number three, for checking the main symptoms in the sick child. Number four, for checking the nutritional status of the child. For assessing the feeding pattern of the child and checking the immunization status and assessing any other problem. Now, when you communicate with the caretaker or the mother, you should have this thing in mind, that you have to listen carefully what the mother or the caretaker says. And you should use the words or the language which the mother understands, and you should avoid using any medical terminology. And give the mother some time to answer the questions which you are asking. And if she is not clearly answering the questions, or if she is not clearly understanding what you are asking, you have to ask additional questions so you get a clear picture of the appropriate problem. Now, coming to the chart, as you can see, the first thing is checking for the danger signs. Now, the danger signs should be routinely checked in all the children, and the danger signs are number one is if the child is persistently vomiting, or if it vomits out everything. The other is that if the child has become unconscious, or if you can see that the child looks lethargic, or is unable to drink, or is unable to breastfeed, and has convulsions. So all these signs are the danger signs. Now, if any of these danger signs, like one or more of these signs are present, then that child is considered as a seriously ill child, and it, as you can see in the box, it falls into the pink section, and the pink section designates that it's a very severe disease. Now, when there is a very severe disease, if the child is having convulsions, if you see that convulsion has occurred in the health facility, you give diazepam instantly, and you quickly complete the assessment, and if any pre-referral treatment is required, you give it immediately, and you refer the child to the hospital urgently. So this is the assessment for the general danger signs. Now, in the next section, after checking the general danger signs, now the healthcare provider must check for the main signs and symptoms. Now, according to IMNCI guidelines, the following signs and symptoms should be checked, like if there is cough or difficulty in breathing, or there is diarrhea, or is there any fever, or any other ear problems. Now, here in this chart, we will first consider the cough or difficult breathing, or the mother or the caretaker brings the child with the coughing or difficulty in breathing. Now, if the child comes to you for coughing or difficulty in breathing, first assess the danger signs. If the danger signs are not present, then you do the clinical assessment. In clinical assessment, you have to ask for how long the child is coughing, and you look for the number of breaths in 1 minute. Now, while counting the respiratory rate or the number of breaths in 1 minute, you see that if the child is from 2 months up to 12 months of age, fast breathing is if there are 50 breaths per minute or more. And if the child is between 12 months to up to 5 years of age, fast breathing is considered when the breathing is 40 breaths per minute or more. So you have to assess the respiratory rate of the child. Now, after assessing the respiratory rate of the child, you look for chest indrawing, and then you look and listen for stridor, and then you look and listen for any wheeze. Now, while counting the breaths, looking for chest indrawing, looking and listening for the stridor, and looking and listening for the wheeze, you must keep in mind that the child must be calm throughout this whole examination. Now, no single clinical sign has a better combination of sensitivity and specificity to detect pneumonia in children under 5, then respiratory rate, specifically fast breathing. Now, even auscultation by an expert is less sensitive as a single signs and signs. So after doing this, you classify the children in 3 categories. Now, when you classify into 3 categories, in number 1 category, this includes the children if they have any general danger sign or if stridor is present in a calm child. Now, if this is present, as you can see in the box, this indicates that there is severe pneumonia or a very severe disease. Now, this child should be given intravenous antibiotic if it's available there in the facility, and urgently referred to the hospital. Now, in the second category, as you see, if there is chest indrawing or fast breathing, as I told you, fast breathing should be categorized according to the age of the child. Then this category falls into the yellow box, and the yellow zone tells us that there is pneumonia. So in pneumonia, you give oral appropriate antibiotic like amoxicillin for 5 days. If there is wheezing, you can give an inhaler bronchodilator for 5 days. Or if there is cough, you can give an antitussive to soothe the throat. Or if coughing is more than 14 days or recurrent wheeze occur, you have to refer that child urgently to a hospital for tuberculosis assessment or asthma assessment. And after doing that, giving all this management, you advise the mother to take the child home and come back after 3 days for follow-up. Now, in the third category, if there is no sign of pneumonia or very severe disease, that falls into the green category. Now, in this slide, there is some problem, so that green color is not properly displayed. It is displayed as a blue color. So, we classify that child as having no pneumonia, having cough or simple cold. Now, in this condition, if there is wheezing, you can give inhaler for 5 days. You can give any cough syrup for soothing the throat. Again, if the cough persists for more than 14 days and the mother comes to the health facility, you have to refer the child for the possibility of tuberculosis, or you can assess for asthma as well. And then you have to, after assessing all this, you have to tell the mother to take the child home and come back for, after 5 days for follow-up if the condition of the child is not improving. So according to this chart, you can assess about the pneumonia, the very severe disease, and cough and cold in a sick child when it is brought to the healthcare facility. So the next category is that a child comes to the health facility with a complaint of diarrhea. Now the diarrhea can be in 3 forms. There can be acute watery diarrhea, which includes cholera as well. There can be dysentery, which is the bloody diarrhea, or there can be persistent diarrhea. Persistent diarrhea is the diarrhea that lasts more than 14 days. So the child can present with any one of these forms. Now, when the child is brought to the health facility, you have to ask the caretaker or the mother about the duration of diarrhea, and is there any blood in stool or not. And you have to do the clinical assessment. For clinical assessment, you have to look for the general condition of the child. Depending upon the degree of dehydration, a child with diarrhea may be lethargic or unconscious, which is a general danger sign, as I told you before as well. Or it can look restless and irritable. So irritable child is that child who cannot be consoled and calmed, and should be then considered as a restless or a irritable child. So you have to look for this thing. Then you look for sunken eyes. Now the eyes of a dehydrated child may look sunken. Now in severe malnourished children like in marasmus, the eyes can also be sunken, but there is wasting as well. So that is a different thing. So even though the sign sunken eyes is less reliable in a visibly wasted child, it can still be used to classify the state of dehydration in a child. So next you are going to look for that if you offer fluid to a child, what is the reaction of the child. Now is the child is able to drink the water or whatever drinkable material you are going to offer to the child, or is drinking poorly, or if the child is drinking water or whatever you are offering him, and he drinks or she drinks it eagerly, means that the child is thirsty. Now if the child is thirsty, it is clear that the child is not that much dehydrated and wants to drink more. Now next you are going to look for the elasticity of the skin. Now when you check the elasticity of the skin using the skin pinch test, now when you pinch the skin and when you release it, the pinch goes back either very slowly, that it takes longer than 2 seconds, or it goes back slowly. Slowly means that the skin stays up even for a brief instant, or immediately, that it goes back immediately. So in a child with marasmus, like severe malnutrition, the skin may go back slowly even if the child is not dehydrated. So these are all the basic conditions you are going to look for, and then you are going to classify diarrhea. Now, when you classify diarrhea, you are going to classify into three types. Now, one is for the dehydration. Now, for dehydration, number one is the severe dehydration. In severe dehydration, if two of the signs are present, which like the baby is or the child is lethargic or unconscious, or there is sunken eyes are present, he is not able to drink properly or is drinking slowly, and the skin pinch goes back very slowly. So if two of these signs are present, then you mark that child as having severe dehydration, and it falls into the pink zone, as you can see in this chart. Now, for that child, if the child has no other severe classification or no other severe condition, you give fluid for severe dehydration according to the plan C of WHO. Now, plan C will be discussed after this slide in detail. So you are going to give fluid to that child. Now, if this child has any other severe classification, you refer urgently to the hospital, while telling the mother to give frequent sips of ORS on the way if the child is drinking slowly, and you advise the mother to continue breastfeeding if the child is able to drink. Now, if the child is 2 years or older and there is cholera in your area, you have to give antibiotic for cholera and refer the child urgently to the hospital. Now, next form of dehydration is some dehydration. Now, if the two of the following signs, like if the child is restless or irritable, as I told you before, how can you say that the child is restless or irritable? Or if the child has sunken eyes, or he drinks eagerly and is thirsty, and the skin pinch goes back slowly, you mark this child as having some dehydration. If two of the signs are present, then you mark this child as having some dehydration, and it falls into the yellow zone. Now, in this child, you give fluids according to the plan B, which is given by WHO. Plan B will be discussed later on, and you give zinc supplementation and some food for some dehydration as well. Now, if the child has any severe classification, you refer that child urgently to the hospital for further treatment. Now, if the child does not have any severe classification, you continue with the plan B and advise the mother when to return immediately and come for follow-up in 5 days if the condition of the child is not improving, or if there is any emergency, she should come to the facility immediately. Now, next form of dehydration is that the child is not showing any signs of dehydration, and you are not able to classify as some or severe dehydration. Now, this falls into the green zone. Green zone, as I told you before, in this slide looks like blue because of some color problem in the laptop. So in green, if the child falls into the green zone, then you advise the mother to go back home, give fluids, give zinc supplementation, and to give food like bananas or mashed potatoes to treat diarrhea at home. And plan A is followed here, and you tell the mother how to follow the plan A, and you tell the mother to go home and take care of the child, and should come up for follow-up in 5 days if the condition of the child is not improving. So these are the 3 stages of dehydration which can be classified with the child having diarrhea. Now, if the child is presented with the diarrhea for 14 days or more, as I told you before, that condition is called as persistent diarrhea. Now, when the child comes for persistent diarrhea, it can be classified into two types: as a child having dehydration, as a child having no dehydration. Now, if the child has dehydration and falls into the pink zone, it is marked as severe persistent diarrhea. Now, in such condition, you treat the dehydration before referring the child, unless the child has any other severe classification, and then you refer that child to the hospital for further evaluation. Now, if the child has persistent diarrhea and there are no signs of dehydration, that falls into the yellow zone. Now, in yellow zone, you advise the mother how to take care of the child with persistent diarrhea. You advise her to give enough fluid to the child and give nutritious food to the child so that his the deficiencies of multivitamins and minerals could be improved. And then if she thinks that the condition of the child is not improving, she should come for follow-up in 5 days. So this is about the management of the persistent diarrhea. Now the third type of diarrhea, as I told you, is the diarrhea with blood in stools. Now if the mother comes with complaint of blood in stool, that is dysentery. So for dysentery, as you know, it's basically Shigella. So you give ciprofloxacin for 3 days to the child, and you tell the mother to take their child home and come for follow-up in 3 days. Now, in the previous slides, I told you about the different plans which can be used for the diarrhea to treat dehydration. We talked about plan A, plan B, and plan C. Now, all these plans have been discussed with you in detail in the acute diarrheal diseases, so I am not going to go in detail, but I'll try to discuss a little bit about these plans. Now, first was plan A. I told you that plan A is given to those sick children who do not show any signs of dehydration, but they still have diarrhea. So to treat diarrhea, and those children are also told to go home, and their caretakers or the mothers are told to treat diarrhea at home. Now, when the mother is told to go home, she has to counsel about certain things. So there are basically 4 rules for home treatment. Number 1 is to give extra fluid. Number 2 is to give zinc supplementation, which is recommended for the age 2 months up to 5 years of age. Number 3 rule is to continue the feeding. And number 4 is the follow-up. That is telling the mother when she should return to the health facility if required. Now, according to these 4 rules, the plan is continued. Now, the number 1 rule I told you is to give extra fluid. Now, fluid is given to the child as much as the child wants to take. You have to tell the mother to breastfeed the child frequently if the child is on breastfeed, and if the child is exclusively breastfed, give ORS or clean water in addition to breast milk. And if the child is not exclusively breastfed, you give one or more of the following solutions like ORS. You can give food which is based on fluids like soups or rice water, or you can even give additional clean water to the child to prevent the deficit. Now, it is especially important to give ORS at home. Now, you have to teach the mother how to mix and give ORS. And usually, when the mothers are told to go back home, the health facility provides at least 2 packets of ORS to use at home. Now, when you tell the mother to take the child home and to give ORS, you have to teach her how to mix it and how to give it. Now, up to 2 years of age, 50 to 100 ml of ORS should be given after each loose stool. And if the age of the child is 2 years or more, then 100 to 200 ml after each loose stool should be given. Now, you have to teach the mother that she should give frequent small sips to the child from a cup or with the help of a spoon. And if the child vomits, then she should wait for 5 to 10 minutes. And then again, she should try to give ORS with the help of a cup or with the help of a spoon. And she should continue giving extra fluid until the diarrhea stops. Now, the second rule was to give zinc. I told you that zinc supplementation is only given to those sick children who are within the age group of 2 months up to 5 years of age. Now, you have to tell the mother how to give zinc. Usually, zinc tablets are present, and that the potency is 20 milligram tablet. Now even zinc suspensions are also available, but usually in the health facility tablets are present. So up to from 2 months up to 6 months of age, half tablet daily for 14 days is given, and from 6 months or more, one tablet daily for 14 days is recommended. And you should also tell the mother how to give zinc supplements. In the infants, the tablet, half tablet is dissolved in a small amount of ORS or a clean water, and it should be given with the help of a spoon. And if the child is bigger, if the child can chew or swallow, it should be given with the help of water. And you should also tell the mother to continue feeding if it's exclusively breastfeeding. If the child is 6 months of age, then she should continue with the breastfeeding. Or if weaning has started, or if the child is older, then she should continue with the feeding. And you should also tell the mother that she should return if there is any complication and if the follow-up is required. So this is all about the plan A. Now next was the plan B. Now the plan B was for the treatment of some dehydration with ORS. Now usually the child comes with some signs of dehydration, and that child should be the caretaker of the child or the mother should be told to keep the child in the clinic for at least 4 hours so that the dehydration could be corrected. Now we have to determine the amount of ORS to give during the first 4 hours when the child is in the clinic. Now the amount of ORS is calculated according to the age and weight. Now, if you know the age of the child, then you do not need to calculate the weight of the child. You can determine the amount of ORS according to the age of the child, and this the small chart which you can see in this slide. With the help of this chart, according to the age, you can assess the ORS amount which has to be given. And the same thing that you have to tell the mother how to give ORS during this time, and after the 4 hours you have to reassess the child and classify the child for dehydration, and then you select the appropriate plan to continue treatment, and along with it you have to begin feeding the child in the clinic. Now if the mother doesn't want to stay in the clinic for 4 hours, you should also counsel her regarding the treatment, that she should go home and give the required amount of ORS to the child at home. You should show her how to prepare the ORS solution at home. You should show her how much ORS should she give to the child in the 4-hour treatment and at home, and she give her enough ORS packets to complete the rehydration, and you also additionally give 2 packets as recommended in the plan A. Now, and again, you have to explain the 4 rules of to home treatment, which I have explained in Plan A. So, this is all about the Plan B. You have to assess the child according to the state of dehydration, and then you should proceed with the plans which are recommended by the WHO. I am not going to go into the detail how you should prepare ORS packets, and how you can make ORS solution at home, as you are taught in detail by Dr. Zatasha in the previous tutorial about that. Now, the next plan is the plan C. As I told you in the previous slides, that plan C is for the severely dehydrated child who shows any 2 of the signs, like if he is lethargic or is unconscious, has sunken eyes, is not able to drink or is drinking poorly, and the skin pinch goes back very slowly. And this child is marked as a severely dehydrated child. And for severely dehydrated child, as it falls into the pink zone, so that child needs to be urgently transferred to the hospital if another severe classification is present, or that child should be started with plan C until the transfer is made available. Now, when the child is in the health facility, you just assess that can you give intravenous fluids immediately. If yes, you start the IV fluids immediately. And if the child is able to drink ORS by mouth while the drip set is being set up, you start orally ORS to the child, and you start the drip set. And in the drip, you can give 100 ml per kg body weight of ringer lactate solution, or if it's not available, you can start with normal saline. And the doses are given according to the age of the sick child. Now, if it's an infant that is under 12 months, in the first hour you have to give 30 ml per kg body weight, and then in the next 5 hours you have to give 70 ml per kg body weight. And if the sick child is between 12 months to 5 years of age, in the first 30 minutes you have to give 30 ml per kg body weight of the IV solution, and in the another 2.5 hours you have to give 70 ml per kg body weight. And you have to check the radial pulse to see if the child if the radial pulse is still weak or is not detectable, or is it improving. And you reassess the child after every 1 to 2 hours, and if the hydration status is not improving, you have to give the IV drip more rapidly. And then in the meantime, you also start the ORS if the child is able to drink within that time period. Now, if the IV treatment is not available nearby, then you try to pass the NG or the nasogastric tube if any trained personnel is present in that health facility, or you try to give ORS to the child if he can drink, and you try to transfer that child as early as possible to the hospital for further treatment, where the child will be reassessed and IV therapy is started as soon as possible. So you have to assess the child accordingly, and you have to start those plans according to the state of the child.